Good afternoon, everybody, and welcome. Welcome to what's going to be the first of our thematic innovation ecosystems, which are focusing on mental health. We're doing this session today, as you would have seen on the previous slide. We're going to be recording this. If you don't want your face to appear on a screen, please remove your video image. That's fine, and obviously mute yourself. We've got a really packed program today, and we're bringing this to you not only as the European Connected Health Alliance, but really excitingly with a partnership with two of our ecosystems, both the Norway Health Tech ecosystem, which has recently joined us, and also our Cologne-Bonn ecosystem, the Gesundheitsregion Cologne-Bonn in Germany, which is fantastic because what this is about is trying to bring in and involve our ecosystems and our members. Let's just crack on. You've seen we've got a packed program today, some really good ideas. That the whole concept of this session today will actually come on to if we can. So Alliance is our director for ecosystems and membership. Who are we? Well, we're a member organization. Global on the left-hand side to promote your organization and also for getting involved with our ecosystems, which is what we're doing today. So how we do that, I'll come to later on. But they join us because they want to get involved with another 850 plus organizations of different sizes and varieties, mostly not-for-profits and public bodies. Let's have a look at the next slide. We've got an ecosystem network that's growing. Our ecosystems bring together all the stakeholders in health and social care, and you'll see that on our logos. We now have an ecosystem network of over coming up to 70 ecosystems. By the end of summer, we'll be opening up in Japan many years ago. But that growing network of ecosystems is growing because people want to collaborate more and work together more collaboratively, just like the people who are doing here today from Quebec, who we got featured, from Scotland, who were featured, from Germany and from Norway, which is fantastic. It's a first for us. And also featuring some of our members too. Let's have a look at the next slide, because as well as building a network of geographic ecosystems, we've built this brand new model in 2021 of thematic ecosystems, because our ecosystem said, look, Andy, very nice to do the geographical stuff, but we want to go a bit more deep dive on issues such as mental health, which we're looking at today, or skills for health, in lights already for the integrated care ecosystem, the digital health and wellbeing ecosystem, skills for health, and today the meeting that you're in is the mental health one. These are still going to be the same types of ecosystems we do as our geographical ones. They're both geographically based, they're permanent. Obviously, these are thematic, but they're permanent. So there's a series of these, and they lead with a need. They're breaking down those, transforming healthcare, but also creating economic opportunity. It's the same in the thematic areas as they are in the geographical area, but that permanence is there. And what we're going to concentrate on today, if you look at the next slide, and the topic subtopic today is isolation. Because mental health, we could start anywhere, and it took us ages to come up with which is the area that comes up. What seems to come up on the news time after time from the start of the pandemic was phrases being bandied around. Now going to be around mental health, but time and time again, the constant topic is around isolation. My background's in mental health and psychiatry, and spent over 30 years working in the field. But what we want to look at today is on a specific topic of isolation. What's the need, and what does good look like, or even what could good look like? So, next slide, please. You can join us as a member organization, okay? Follow us on Twitter, get involved with that. But I'm going to stop talking, which for many people will be a surprise, because I'd like to go on to the first of our subject matters for today. I'm going to bring on our first speaker from one of our member organizations, which is going to be was one of our very, very, very well-connected organization for the Agile, founded Agile Alliance. And he's going to give you just a brief introduction in terms of what his understanding is around the topic and the whole area around housing. So I'm going to hand over to Ian now.
Thank you, Andy, and thank you for inviting me to participate in this gathering today. I think it's very interesting to be looking at mental health at this time, and specifically in relation to, you know, a post-pandemic world. What can we do about it? My particular lens through the Agile Aging Alliance is looking at how the built environment can make a difference. And for those of you who are not familiar with the Agile Aging Alliance, a brief resume. I set up the organization 2015 off the back of some work that I was doing for Innovate UK, which is the UK government innovation agency, and that was called the Long-Term Care Revolution, and that was all about deinstitutionalizing long-term care, i.e. keeping people out of the pandemic have suffered the most, people in them. But going beyond that, the European Commission recognized through research that some 80+% of European housing stock is not fit for purpose for an aging population because it's just not right. Physically, it isn't fit for purpose, and there's a lot of work to be done. So we've been running a program for the past 6 or so years called Neighborhoods of the Future, and that's about planning for the future. It's about what good could and should look like. It doesn't ignore the fact that the vast majority of housing is already built, so there needs to be retrofitting. But specifically looking to the future, how can we plan different? One of the primary considerations is the health of an aging population. And it's been identified, if we turn to the first slide, that social isolation can be as damaging to health as smoking 15 cigarettes a day, and this has been identified by WHO. It significantly increases a person's risk of premature death from any causes. It was also associated with about 50% in terms of increased risk of dementia, and poor social relationships associated with 29% increase of heart disease and a 32% increased risk of a stroke. It's also associated with higher rates of depression, anxiety, and suicide. Consequently, through our research, and this was pan-European, as I said, it was enabled by the European Commission, our findings, and this was in 2016, was what we should be looking for is a multi-generational future. The idea of fantastic American-style retirement communities actually is not what people really need looking to the future. You can end up with elderly ghettos, which is not a good look. It's not something that actually is good for people's health. You do need to have that integration. And if we turn to the next slide, our approach, the Agile Aging Alliance, is about working together collaboratively to make a difference. And that's obviously consistent with the aims of this ecosystem. What we're doing is working closely with ISO, who approached me about a year or so ago and said, would I be interested in leading the development of a new standard for multi-generational neighborhoods or communities. The standard is officially known as the development of smart multi-generational neighborhoods. So the technologically enabled neighborhoods is really important. And what we're doing is we're conducting research across the board with different stakeholders, and we have put together a number of demonstrators in different countries whereby people are actually, when I say people, developers are actually building with these principles attached, building new developments with new forms of health with academic partners. So we've got a research piece. Now we're connecting the dots between these test beds across, well, actually across the world. We've got them in the USA, we're working on one in Japan, UK logically. We're working with Shapes on a pan-European project, which Alexa will talk about a little later. And long story short, we are in the process of building this connected innovation hub. And it's an opportunity for perhaps some of the organizations working, participating here today to get involved. We're open to input. Our next event is in October. And I think that really kind of defines, from my perspective, why it's essential to make a difference in terms of improving the quality of life for an aging population and avoiding social isolation. We do need to plan more intelligently in terms of our neighborhoods of the future.
Excellent. Thank you for that, Ian. As always, a really useful input. And I've been involved with several of Ian's events within the Agile Aging Alliance. I can only encourage all of the people here today to get signed up, because they're fantastic events and make stuff happen. And I've seen it grow from what seemed now quite a long time ago to, I think, a really, really exciting movement, as I would say. So thank you for that. Okay. Very, very useful. So we've got one lightning speech from the side, and we heard there in terms of the real impact that isolation can have. And I think those figures speak for themselves. And there's a, so what do we actually do about it message from me in there to get involved. Next, what we've always done with our ecosystems is again to try and bring in the need from either patients and citizens or not-for-profit organizations, like we've just done, but also from carers as well. And so we're really, really pleased to bring in what was this year our 800th member, Eurocarers, to bring in Stacey, who's going to talk about Eurocarers, and in particular the idea or the need from carers around isolation. Because if you think about, you know, the very often the images we see around isolation, those pictures of people, you know, sat on their own. They're usually either young people or older people, but people have been isolating on their own as carers for some considerable time. Nothing to do with the pandemic. They're isolated. Stacey, over to you.
Thank you, Andy, and good afternoon, everyone. I'm delighted to be part of this conversation because, not least because, as Andy mentioned, we recently joined the network. So it is actually my first opportunity to interact with the network, and I'm very pleased for that opportunity. So yes, my job this afternoon is to try and shed light on the situation and needs of informal carers and the impact of informal care on carers' isolation and mental health. And in the process, I'll try and shed light as well on the impact of the pandemic, with your permission. So next slide, please. So first of all, what do we know about the situation and needs of carers in Europe, based on EU research or either by the EU institutions themselves or funded by the EU institutions? And so most of the data, or pretty much all of the data I'm going to use now is reliable or can be considered as such. First of all, what we know is that informal carers, so family members, friends, and neighbors, have a crucial role in the provision of long-term care in Europe. According to some estimates, as much as 80% of all long-term care in Europe is actually provided by informal carers today. So informal carers make up, depending on the definition, between 10 and 20% of the EU population. So it's a fairly significant group. Unsurprisingly, I was going to say a typical carer is a woman between 45 and 75 years old. And that's a very convincing point. We find the economic value of care or informal care. That means the contribution of informal carers to the economy is also estimated by institutions at between 320 and 368 billion euros per year, which exceeds, for pretty much all of the member states, the expenditure for formal long-term care services. So what that means is that if we were to try and replace informal care by professional care, it would actually reveal completely impossible. So informal care is important and is there to stay. There's no access to universal long-term care in Europe without informal carers. Next slide, please. When it comes to the impact of informal care on carers themselves, again, based on research and evidence, it's very well documented. First of all, a majority of carers struggle to maintain an active social and professional life with their, as a result of their caregiving responsibilities. And so as a result, many fall into poverty, also because they tend to contribute financially to the care costs or, for the care recipient in terms of adapting homes or, contributing to the, medical costs. And many face social exclusion because they're not in employment, but also because, their caregiving responsibilities are often extremely demanding, and so they are completely isolated. And based on the statistics at our disposal, we see that many feel lonely and and isolated, which is of course the topic for today's discussion. And so as a result of that, many also face mental health issues, so depression, suicide or thoughts about suicide. And this is obviously a vicious circle, because then informal carers become patients themselves, and that also has a cost. Next slide, please. What about the impact of COVID on carers? Well, you won't be surprised to hear that the pandemic has done nothing but exacerbate all of the challenges I just mentioned, which pre-existed the crisis. Carers are more isolated than before, ever before, as a result of the crisis. And the main reason is that, of course, the lockdown measures, strict lockdown measures, and the reallocation of care services to the most urgent needs mean that carers have been deprived of the support measures at their disposal when in existence, as a result of the pandemic. And what we did on our side is, between November 2020 and March 2021, we conducted an EU-wide survey among our member organizations, so 75 organizations in 26 countries, to try and collect information and data about the impact of the pandemic on carers. And now, in the next few slides, I will try and highlight some of the learnings, obviously only a selection. So the next slide, please. When it comes to the impact of the pandemic on carers' personal and caring circumstances, and the most impacted aspects of the carer's life, as you can see, the quality of life and the psychological state of mind are are part of the top 5 in terms of the most impacted aspects. Again, feeling of isolation, loneliness, and depression are very big problems among carers. And from our perspective, really, this is a time bomb. It cannot be. We can no longer ignore the needs of carers in the long run, and we need to provide them with the recognition and support they need. The other interesting learning from the survey is that many carers actually provide more care as a result of the pandemic. 17% increase in terms of the number of weekly hours of care, which, by the way, before the crisis was already amounted to 46 hours per week, which was already pretty significant. And so that's increased as a result of the pandemic. More intense care as well. And there, the most striking element in our survey is the provision of emotional support. Again, not only carers, but care recipients felt isolated and lonely as a result of the lockdown measures. And so emotional support, became a central part of the caregiving responsibilities for many informal carers in Europe. And then last but not least, a new population of carers emerged from the crisis. So people stuck at home and suddenly having to deal with caregiving responsibilities because, as I said before, care services suddenly were more limited or unavailable. And so families had to take over or to take on caregiving responsibilities. Next slide, please. In terms of the impact of on access to care services for both carers and care recipients, well, first of all, it is important to mention that not all carers have access to care services and support measures. And among those who had access to care services before the crisis, that's about half of our respondents. 1/3 report a decrease in the support. In terms of the most effective sources of support during the pandemic, that's also a very interesting learning. You see that pharmacists and GPs are 2nd and 4th on the list. And actually, that's completely new. Those people did not appear on the list before the crisis. And the key learning there is that, we've been pushing in our organization for a long while now, for more information to be provided to primary care actors who are very well placed to identify, provide information and support to informal carers. And the crisis now demonstrates their importance for carers when in a situation of emergency. More than half of carers feel not sufficiently supported, irrespective of the crisis. So again, it shows how severe the impact of informal care is on carers, but also how urgent it is in a way to address those needs. Next slide, please. In terms of the action points, based on our general work, but also on the survey, as I said before, I think there's a lot of room for maneuver and room for improvement when it comes to the interface between formal and informal care. So the relationship between informal carers and healthcare actors, and in particular primary care actors. So GPs, pharmacists, nurses, physiotherapists. So more information, more training needs to be, and awareness raising campaigns probably need to be organized and targeted at those people to ensure they are well equipped to respond to the needs of carers. The role of civil society organizations has been extremely important during the crisis, I think, not only when it comes to informal carers, but generally. And I think that's another key message that we should all convey to decision makers following the pandemic. Because as we all know, many civil society organizations work with extremely limited resources. This is certainly the case of most of our member organizations. And when it comes to informal carers and the services developed, innovative services developed by our member organizations to help carers, and in relation to social isolation and mental health issues, I'd like to flag a few, specific activities. First of all, the development of hotlines, either online or by telephone, to respond to the questions about COVID, about caregiving. That's proven extremely useful for many carers, and there was a clear demand for that. Then having access to peer-to-peer support is extremely important for carers and extremely useful. And there again, ICT-based solutions can easily be, developed and used to give access to that kind of support measure. And then respite care, but then respite care has been drastically reduced during the crisis. And there again, we need to learn our lessons from the crisis, for the future. And then very last point and completely new aspect that emerged from the survey as well is the aspect of cross-border informal care. So we've seen cases, for example, of carers who are based, for example, in Brussels, or carers for their mom or dad who are based across the border in the Netherlands, for example. Suddenly, as a result of the lockdown, they were unable to travel to the Netherlands, and then there's no one to take care of their family member, and no statute to actually allow them to cross the border. And so that's another very interesting aspect emerging from the crisis. I think I'll stop there for now, but I'm happy, of course, to answer all questions and to contribute to the discussion afterwards. Thanks.
Thank you very much, Tessie. Very, very informative. I think a really round picture of the needs for informal carers. I'm going to move swiftly on for our next presentation, and we'll have some questions, time for questions at the end. So let's start looking at what the need is, and we've got two speakers today, and what we're trying to do is mix things up a little bit. So we're not necessarily having PowerPoint after PowerPoint after PowerPoint. So we're going to bring in some specialists from the Cologne-Bonn region. So it's Dr. Elizabeth Robach and also Mark Grindle from Scotland. But first, I'm going to ask Dr. Elizabeth Robach, please, to introduce yourself and tell us what you think, obviously who you are, and what you think the need is around isolation, please.
Thank you, Dr. Bleeden. May I introduce myself? I'm working in a small hospital for psychiatry, psychotherapy in the center of Cologne. We are called Tagesklinik, but we are also a clinic, a small clinic for mental health in our city, in the middle of Cologne. I wanted to talk about loneliness, mental health, and the impact of a pandemic. To begin with, loneliness itself, it's not a disease, it's not a mental illness. Loneliness is a feeling, a sensation. Sometimes we need being alone, we look for it. If you ask people about their wishes, for example, for the new year, they often want to have more times for themselves. What is loneliness? Loneliness is the feeling of being thrown back to oneself. In the German language, we only have one word for it, it's Einsamkeit, and that has a predominantly negative meaning. In our language, we do not differentiate between loneliness and solitude. Everyone knows loneliness. It overtakes everyone at times, one when alone, the other when in community. People with mental illness have significantly fewer opportunities to use loneliness, to deal with, to cope with, and are less confident to find a way out of loneliness again. Mentally ill people need a real person in contact to feel themselves, to experience themselves. They often depend on the real presence of a person. They can't do with too much closeness, and they can't do completely without other people. It is problematic when loneliness becomes chronic. Then loneliness can make you really sick, can cause real pain. Those who are chronically lonely do suffer. If the negative side of loneliness, characterized by despair, predominates, then loneliness makes people ill, as Dr. Spiro pointed out already. Human closeness is essential for us as human beings. Chronic loneliness is an extreme health risk. Lonely people have a significantly reduced life expectancy, are more likely to get serious physical illnesses, heart attack, stroke, cancer, and die significantly earlier. Loneliness is as harmful, as Dr. Spiro pointed out, as smoking about 15 cigarettes a day for a long time. Loneliness seems to be epidemic in our society and in our time. The social network has an influence on our health. Loneliness experienced in a purely negative way affects health because it puts people under chronic stress. Isolation stresses people. Effective against the feeling of being alone are one social, a member of a choir, for example. This can make people satisfied, locates them in the world, gives them a sense of meaning in life. On the other hand, it's critical for people if they have no social roles and do not feel connected to other people. Loneliness also is reduced with a social problem. Socio-economic status is also significant, as for example, income, education, living environment. If you have a low social status, you have fewer opportunities to move around, to get out of loneliness. We all long for other people, for contact. However, we have different ways to getting in touch with people. In our society, even before Corona, it has not been easy to feel connected to other people, especially if you are mentally ill. Under the long lockdown during the Corona pandemic, this became even worse. During the Corona period, a lot of things got out of balance. Outpatient structures and also low threshold opportunities to contact other people were cancelled. Self-help groups no longer existed due to Corona. Later they took place via video. Medical and psychotherapeutic treatment also took place via telemedicine and online. Face-to-face encounters were very much reduced. That changed a lot and led to further increase of loneliness. For people with mental illnesses, with addictions, with anxiety disorders, with psychosis, isolation often increased. People withdrew more. For many people in the pandemic, there's first fear of infection, of getting sick, then isolation, family overload, worries about financial losses, job loss. Especially people who do not feel well connected, who suffer from loneliness, hardly withstand these further stressors. We see the impact on mental health in our clinic. Depression worsens, anxiety disorders increase, addicted people relapse under the isolation, consume more alcohol and drugs. People suffering from psychosis related the danger to themselves, lost touch with reality and even more. What about healthcare and community institutions? What can we do here? What are the experiences in other countries? What can we do in the healthcare system to offer help for people for whom loneliness and isolation have increased, especially during the pandemic? We can offer low threshold help here with the clinic, the day clinic, the outpatient clinic. We do. How can we create places in our community, in our city, in our clinic where people can meet? How can we help prevent people from becoming involuntarily lonely? How can we open spaces, let people participate in life in the community? These are some thoughts on loneliness that I wanted to share with you today. Thank you very much for your attention.
Vielen Dank, Elizabeth. That's very, 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 very good. Very informative, and I think a really good insight into the actual impact of loneliness from a psychiatric point of view and a psychological point of view. And very important, I think, gives us food for thought. Always useful within our ecosystem to see where the need is. So thank you very much. Very informative. From the picture in Germany, I'd like to perhaps now move, if I could, and introduce our colleague from our Highlands and Islands ecosystem, Dr. Mark Grindle, who wants to concentrate, again, and without needing to rely on science here, to give you an insight into some of the testimonies, I think, from people about the need around isolation. So Mark, please give us your input, please.
Okay, thanks, Andy. Can you see and hear me okay?
Yes, yes.
Yeah, I just want to just stand back a little bit here because, you know, none of us can ignore the stats. None of us can ignore the news headlines. None of us can ignore the impact of COVID upon mental health conditions that were there before. And certainly none of us can ignore the long-term impacts that we're having to address. And I guess it's really a question I think we need to ask ourselves some key questions around what the needs are. And I suppose my first question is whose needs are we talking about? Well, obviously the needs of those who are most in need, but also, you know, we're also talking about an economic environment here. And part of that means, okay, well, so how do we align those needs with opportunities? Now, it seems wrong somehow at a time of crisis to be looking at opportunities, but actually, well, if people are focused on economic opportunities that are going to save the NHS money, that are going to save people and carers time and effort, then why wouldn't we do it? Okay. My work is mainly around the use of digital technologies, and in particular the use of audiovisual and interactive entertainment in the field of health behaviour change and mental health. And my focus is particularly on the mental health of young people and adolescents. And again, there's stats, there's testimony. All we need to do is go online and look at look at what's happening in pockets, particularly those that are socioeconomically deprived in Scotland, and you'll see that that COVID has exacerbated social inequalities that were there before. Okay, so what do we do about it? Yes, we identify the need, but at the same time, it's very hard to talk about the need without starting to think about what some of the solutions might be. And I suppose what I'd argue is that in all our conversations around isolation, we put ourselves in a bit of a trap, because all we're saying is, how do we deal with isolation? We already know what the solution to isolation is, and that's integration. So I think our solutions, whether they be digital or real world, need to certainly identify the problems that we all know exist around isolation. But how do we ensure that those people who are most impacted by it can move from a position of isolation to integration? My formative work was in Hollywood, and as a screenwriter and as a producer. And in 1990, I attended a lecture by Peter Guber, who'd done all the Batman films, and he spoke about the importance of emotions and engagement over time with in that case film entertainment, and he used examples from macaque monkeys and evidence from macaque monkeys at the time that shows that any individual that is isolated immediately has heart conditions, blood conditions, develops cancers. We've known all this for a long time, but I think we've been a little bit shy of saying, okay, so how do we move to integration? How do we ensure that those who are isolated move to integration? Some of them, the recent, I want to talk about a little bit, and apologies, Andy, it's their pet project, so if you want to kick me off the stage, let me know. But I do think they're good because the testimony that comes out from them is really pertinent. So we're doing some work with young people with long-term mental health conditions. The emphasis was on how do we create a platform to allow young people to self-manage their long-term mental health conditions. So our starting point was, no, let's not just create an app. Let's just not create an application or a platform. Let's go and talk to them. So we started by engaging with young people with a range of long-term mental health conditions and a large number of them. And in those conversations, it was quite clear that they had certain needs. One was peer-to-peer support, ongoing peer-to-peer support. The other was to be able to hook up with mentors in a safe space. And the other, and I don't. This isn't last but not least. It is last but not least, is they wanted to be able to be in control of their own journey, tell their own story, and be in control of their own self-management. They didn't want the GP telling them, here's a mentor, you know, they're going to work with you. They wanted to be able to be involved in that process, because these aren't people who have the labels. These are people just with different ways of seeing the world. And so we remain platform agnostic. What came back was that need for peer-to-peer support, the need for them to be able to choose their own mentor, and the need for them to feel in a safe space that wasn't intimidating. Okay, so we came up with 3 solutions. One was the use of the Discord platform, where already young people are engaging through games and music and primarily games. But there's a platform there that allows them to hook up with people like themselves. The second platform we developed was a mentor matcher that allowed them to choose from a list of mentors, but also to say if there weren't the mentors they want, then what that mentor looked like. These were their needs, these were their wants. They wanted to choose the color, they wanted to choose when they could access these systems. And the third was a virtual reality component that we've been testing again with young people, and they, in a safe environment, that they could do their mentorship. Now we just got another round of user testing, and the same thing keeps coming back. We love the fact that we can talk to people in Discord in a peer-to-peer way, that we can help people like us, and people like us can help people like me. In the case of the mentor matcher, I felt, and this is testimony, I felt empowered to be able to choose my own mentor. I felt that I was in control of the journey. I didn't feel like I wasn't being told what to do. And in the case of VR, I could choose the space I was in. I didn't have to go into a grey office and sit opposite somebody and feel awkward as if I was doing something wrong. I can be in a virtual space and play and discuss my problems in a way that I want to be able to do. So what we're doing is combining those 3 elements together now. But the learning and the message is clearly, we cannot do this without engaging young people, hearing what they want to do. And it's not just young people, it's an intergenerational concern. We can't separate the healthy aging agenda away from the mental health issues of young people. They are related and technically related. And I think we've got to get away from this sort of slightly silo culture when we are looking at mental health. But the testimony is they want safe places, they want to have peer-to-peer support. Digital has some solutions, yes, not without some concerns around data protection, etc. But unless we embrace it, we're not going to get over those concerns, and we won't be able to address the needs of these young people. So again, those sorts of solutions can give us opportunities to engage with young people over time, so that they feel not just that they're being treated with CBT, that they're being treated with mood juice or whatever the main platform is, but they feel that they are involved and engaged. And it's not just the end result for them, involving them in the process of development to help people like themselves, they find empowering. They find that it brings them to life. We can see that it brings them to life. So for me, it's engaging those people. The starting point is engaging those people and involving them, and not doing a top-down approach. I think that's what the need is.
Engagement's the key. I think that's quite clear there, Mark, and very, very useful input there. Thank you very much for that. Really, really useful. So we've seen from two of our speakers now what the need is. We're running a little bit behind, so we're going to put a little bit of pressure and put the heat under the feet of the next couple of speakers in terms of to say, what's working. So without any hesitation, we're going to get on a virtual plane and fly from Scotland straight over to Quebec and introduce the coordinator of our Quebec ecosystem there, Pascal, please.
Hello all.
Hello.
Thank you, Andy. So I'll go Pitcha Kucha style. This is what I understand, right? All right. So bear with me. Thank you, Alexia. If I can maybe just ask you to flip the slides as we go, maybe every 30 seconds or so. So I think that will be my timer. Thanks a lot, Alexia. So greetings, everyone. So briefly, Numana, we are a think tank dedicated to innovation clusters here in the province of Quebec in Canada. And I'm here today to present to you at least one way that we're looking into finding solutions and what is working. So the Village Initiative is a smart city project. Smart cities are in Canada being granted from a smart city challenge from a few years ago, 2019. And the Village Initiative here is a small borough in Montreal who were finalists in the $10 million category. So they finished in third place. And what the Village Initiative is, that's the YouTube that we will encourage you if people want to take a look at it. And we can go along. Next slide, please, Alexia. Thank you. So the project in itself is a city who is exploring ways to be more in a caring village approach. As we know, it takes a village, and this is the mindset of the authorities of the city to look into tapping into how communities can engage and embrace more in cultural values, because this suburb in the Montreal area is very culturally diverse. And as we know, culture has a big role to play when it comes to caring. And throughout the process of the Living Lab. So we're starting a Living Lab project. So this is the first layer. So the smart city is the first layer. Having obtained this grant, the city is moving forward with an ecosystem, which we are part of, to enable them to embark in a Living Lab journey for the next 3 years. So from 2022 to 2025, we are working with the community groups to find the actual challenges and needs, and everything that was presented by my colleagues since the beginning is just enlightening. And I mean, we don't have anything more to add to what has been added since this morning, although what has been discussed are right now in Montreal with this Living Lab Smart City project being open. So we're opening up a conversation, if we may, for 3 years with researchers that will be on the ground, collecting data of the actual needs in the city towards aging in place in a secure way, and break the silos around isolation, mental health issues, and all of the other issues that we know, where caring is the key here. So technology for us is it's an enabler. It is not the solution. So we're driving into a model where we tap into the actual needs, and technology is an issue here in Canada where we have digital literacy. So it's not everyone who has access to a cell phone, an iPad, a tablet, or even Wi-Fi. So this is something that we are concerned about. How do we tap into people who are more vulnerable, alone, living with issues of aging and do not have technology? So before the pandemic, we had started the Living Lab approach to look into, what if, and these projects are going on around the world, and we saw that with university students, there was maybe ways to pair a student with a senior resident in an apartment, so they can have shared, of course, rent and share time together and develop care culture for students. And then the pandemic broke, so of course that project was put on hold, but it's still something that is being researched through the Living Lab, is how to pair people who are isolated with youth, because youth today, they do want to engage what is going on right now through the pandemic, and even beforehand, the aging issues here in Canada. Youth are very concerned, because when we talk about aging, it concerns all of us. So we're finding ways through the Living Lab, and this is data from the presentation. I encourage you to look into it, in details. But the Living Lab approach is showing that, well, if the person, we can enable technology, there's education. So right now there's we are enabling technology and education to have workshops with elderlies who do not know how to use technology. So that is the first step. And then we're seeing already how with certain visual technology, we're able to notice if the person is feeling lost, ill, or sad. And emotions are a big key here. So this is what we're looking into more and more, is how do emotions through technology can be a player in discovering more earlier someone who is isolated and in distress. So these are the things that we're working on and into, and non-technological ways as well. We're just looking into how can we better think the city's design from an urban perspective and have more gardens and places where people can meet and have socializing in place. To be able to, as we know, like playing in a garden is a big, huge happiness tool for any human beings. So it's just a matter of basically rethinking somewhere where we've dropped the ball here in Canada, and it's caring. We've lost the knowledge of caring in our communities, in our neighborhoods. So the Living Lab approach is to re-educate and bring in cultures from so much areas in the world that are part of the Ville de Côte-Saint-Luc city, and share to us their knowledge from a cultural perspective. How do you care in your country? What are your roots when it comes to caring? It all comes back to humanity. And then technology, of course, comes in, and we know there's so many options that are out there, and technology does exist. So it's not a matter of reinventing whatsoever technology. It's to being able to build a more solid, it takes a village approach. So right now, like I'm sharing, we're walking in the Living Lab project for 2022. So we're putting the roadmap as we speak, with everyone, as you see here, with the Smart Cities role, who must be around the table, and especially the needs. Every individual has different needs. So this is the roadmap that we're putting on. So for the next 3 years, I guess we will be coming back here at ECH Alliance to expose to you the results of what we're walking into here. So this is the smart connected framework that we're working on. So basically, this is part of the team. So again, it's really a matter of connecting people to reconnecting with caring. And as my colleagues exposed before myself, caregiver is a big issue here that we need to look into as well. So I don't want to take up too much time. You asked me to be brief, so I'll cut it there, if I may.
I think that's brilliant, 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 and no other words can say. And there's never too much caring, and there's always space for a little bit more. So I think that's fantastic insight into a really successful approach with using a living lab idea. We've seen the intergenerational shared house, which ties into what was said at the beginning with Ian. So thank you, Pascal. Really appreciate that. Alexia, you're going to bring in now and talk from the German perspective about the Shapes project, I believe.
That's correct. Thank you, Andy, and I hope you can all hear me. I'm multitasking today. So I'm very glad. So my name is Alexia, for those of you who don't know me, and I've been working at the Health Region Cologne-Bonn for the past 5 years. I'm also the head of our house internal GEWI Institute for Healthcare Studies, which is part of the Health Region Cologne-Bonn. And the Health Region is, as Andy mentioned, an ecosystem from the Alliance network, the Cologne-Bonn Rhineland ecosystem. I'm very pleased to be among you all experts here today. And so big disclaimer, I have no mental health background, but what we do within the GEWI Institute for Healthcare Studies is that we are part of a, oh, and it didn't work. I thought I had inserted a slide here, but it didn't work. It doesn't matter, because it was just one slide with the logo of Shapes, which is a project that Ian mentioned at the beginning of within his lightning speech. Shapes is a Horizon 2020 project. It's huge. The consortium lead is University of Maynooth in Ireland. The GEWI Institute is one of the 35 partners, which are among that explorative project. And very briefly, the idea of Shapes, which is putting a focus on healthy aging and connecting older adults thanks to technology, not only connecting them with their own health and well-being data and parameters and so on and so forth, but also connecting them with others. And one of the methodologies used within Shapes, which is really interesting because it's very much explorative, as I said, and iterative. And one of the methodologies and one of the key or the heart, one of the working packages that is at the heart of that project is actually a large-scale piloting plan. So based on the reference sites that some of us know from the old EIP on AHA program that was launched by the EU a couple of years ago by DG Connect. So as reference sites, we are piloting themes. And those pilot themes have chosen, they could develop their own use cases. And the one that we are rolling out in a rural area just outside of Cologne is actually very much what Pascal just described, that he's already not only implemented, but also even collected data and information and has already the feedback. So what we are hoping is to maybe align our feedback with his. I am certainly going to be looking forward to reading more on his project in Quebec. So what our use case is preventing isolation, preventing getting lonely, thanks to technology. And the use case is there to pool information from what is happening locally, let it be weather information, and encouraging people to then go out and enjoy the sun while it lasts, because in the afternoon it's going to be raining, to subscribe or enroll for knitting courses or or computer, like digital literacy courses, just the, you know, basically make available and visible the opportunities for them to connect with neighbors, with people that they don't know yet, with people that they already know but haven't seen in a while. And curiously, the bad news with COVID was that out of the sudden, you know, connection was not, you know, that was like the last thing you wanted to do, is connect with people you didn't know and people outside your own household. But we managed to have, because it's a 4-year project, we managed to kind of redistribute some of the activities in the pilot sites. And it had to be, obviously, it also involved quite a lot of IT development work first. And we kind of reshifted and reshuffled everything. And we were lucky enough to, at least even being based in Germany, we are lucky enough to have our 70-year-old pluses now fully vaccinated. So now we can go back, you know, and actually really motivate them to take part to those into those use cases. Each use case is also being replicated by other of the Shapes projects, by other pilot sites. So what we will really be looking into is having the results, you know, pretty much what Pascal also lined out. How accepted is it? Is it user friendly? Is it actually is it serving, fulfilling the purpose? So it's a very much also co-design approach, because we're now in the phase of discussing with the target groups how to integrate those technologies into their daily lives. Are they the right technologies? Is it, you know, is it something that they is a robot something that they would have in their own home, or rather not? So we very much having that co-design approach. Yes, and that's what will be developed throughout Shapes. I see that Andy has already shared the link. We will definitely be, I mean, if there's any questions, come to me or to my colleague Bettina. You will find her also on the Gavi website, or my contact details, I'm sure you will see in the presentation. I will keep it short because I know that we still have some solutions to be presented, and since I'm kind of organizing this, I'm actually really looking forward to discussing with all of you, and I would much prefer to leave room for that. So cut it short here. Come back to me later. Thanks very much for the opportunity to present.
Thank you very much. There's 2 links there for both the project itself and some of the pilot sites as well. So I think it gives a rich tapestry. This is a project funded by Horizon 2020 through the European Commission. It's important to see. So that's 2, I think, you know, good practice inputs from both our Quebec ecosystem in Canada, and also from within Germany, from the Cologne ecosystem, from their project in Shapes. Now what we want to do is to give a bit more of a richer input. We're looking at, you know, some actual solutions there. So we've brought in Anna from Norway, from an organization called No Isolation. Hopefully the clue's in the title. So Anna, please introduce yourself and tell us about No Isolation, please.
Thank you very much. I have the presentation on my screen. Is it okay if I hijack the screen here?
Yes, please. Yes, that's fine. Yes.
Perfect.
Just press some buttons here and look as if this will take no time at all. And before you know it, your screen and not my face will appear on here.
Let's see what happens if I take this one.
1 second. Alexia or Martine, just let me know when that happens.
Oh.
Anna, I think you can share your screen.
Yes.
You see the, yeah, is it possible for you?
It means I have to leave the meeting and re-enter the meeting.
Okay.
Okay.
How quick do you think you can do that? And in the meantime, I'm going to come back with some questions just to keep the flow going, because obviously these things happen. So if you leave the screen and then come back in, one of the questions I had And just I'll see when you come back in. So that there was one of the questions I had was for Ian Sparrow from Agile Aging Alliance. Ian, do you think people are listening to the concept of multi-generational housing? Because it's not not necessarily a new concept, but people listening, I mean the policymakers listening and the house builders.
I don't think you can go with the generic people listening, and that encompasses all sectors. The reality is that there is a clear requirement to look at how we might do things differently. You've got the circular economy, for example. Let me give you an example. We're working very closely with Clarion, which is the largest social housing agency in Europe. And they're in the process of regenerating significant schemes across the UK at the moment. And these schemes have run for maybe 50, when I say schemes, these are housing developments that have been in place for 50, 60 years, and they're having to knock them down and start again. That doesn't make any sense. It doesn't make any sense economically, and it doesn't make any sense in respect of the way the housing stock is not actually working in accordance with the needs of the 21st century. So from a business perspective, companies are actually looking at how they can do things differently. And if you think about adaptive housing, that is reflective of the needs of society moving forward. People are coming back together, families are coming back together. So you can take one property and you could repurpose that property over its lifetime. In the first instance, it could be a kid's room, it could then be a student's room, it could then be a granny flat. And I'm not just talking about the traditional, this is a small box room, but actually being able to move walls, move doors. So there are so many aspects like that. And then you've got the other underlying aspect in respect of technology. So the actual infrastructure, Internet of Things, other technologies that need to become part of the infrastructure. These are a reality of today. So the bottom line answer to your question is, it's not that they've suddenly woken up to the need for a multi-generational, but the reality is that you need to be looking at universal design in a different light. And universal design was always about inclusivity. So actually starting and thinking more laterally, you know, that there are organizations that are pioneering in this space, and the bottom line, and it's consistent with what you're trying to do here, organizations like ours need to shine a spotlight on those that are doing things differently, and critically we need to come up with the research, the evidence that demonstrates that there is a socio-economic benefit for a different approach.
Yeah, I get that. Thanks for that, Ian. Useful as always. Okay, I believe we're ready for you, Anna.
Yes, do you see my presentation?
Okay, floor is yours.
Thank you very much, and thank you very much for having me here today. It's been very interesting following the different talks, and this is at the heart of what we're working with. So my name is Anna, and I am the co-founder and also the Chief Communications Officer in a company that's called No Isolation, which is basically what it's named. We work to reduce loneliness and social isolation, but we also do it through technology. So I'm going to talk today about Comp, which is a screen that we've developed, or it's actually a full computer, but we've developed it to make sure that people who are 100% analog can still use this screen in a good way and feel the sense of mastery that you should feel when you use a new kind of technology. So it's very simple, but it has a very high value for the people using it. But first, I'm just going to briefly say a bit about No Isolation. So we bring people together through warm technology and knowledge. We work a lot with gathering research and talking to people who live in vulnerable situations to find out what they need. And then we say that we develop warm technology, which is basically technology facilitating actual human contact. So we try to find a certain problem and then we develop the solution to that single problem. Because we completely agree that technology is not the solution for everything and you need a lot of interhuman contact, but where it's possible, warm technology could do some of the things that warm hands do today. But it's very specific problems we're trying to solve. We have another tool that's AV1. It's for children who have long-term absence from school. So with AV1, they can actually be in the classroom. It's an avatar that they control. And then while designing AV1, it became apparent for us that we also needed to look at the very oldest in society and how they are completely sort of on the outskirts of the digital society. There's a few things that was very important when we started working with Comp. It's one thing is that you can't have like a house to signal this is the home button, because if you've never seen a house in that setting before, it doesn't make sense that that's like the start screen. So any kind of like multiple user interface became very difficult. And we also saw that a lot of people, when they become a bit older, the blood circulation slows down and you don't have fingertips that will work very well with the touch screen. So you can see someone pressing an iPad really hard. It's not necessarily because they don't understand how the iPad is working, is the iPad not responding to their moves. So having a touch screen was also out of the question. And we wanted to make sure that it can be used by people with cognitive difficulties and mobility issues, sight and hearing impairments, and also no interest in learning technology or wanting to learn technology. So it was Comp that came out of this. It's designed to take anyone online. It's very simple. It demands nothing from its user, and everything is controlled by an app that's connected to each specific Comp. So you actually twist the button. We tested like 100 buttons to find the right kind of click to make it sound like an old transistor radio. And then it's on. It has a pretty large screen. It's larger than you think. It's like 17 inches. And it also has a matte finish to make sure there's no reflection in the screen, so you can see it even with reduced eyesight, which was very important. It's the app that you use to connect to it. So you invite family members, network, also caretakers, and they can then see what happens on the Comp in a sort of Instagram feed almost. And they can video call and they can send messages. And when they video call, it automatically counts down from 10. So if it's on, the call will go through after 10 seconds. If it's off, then you can see in the app that this Comp is off and you can't reach it. We have about 6,000 Comps out in Europe now, with 50,000 Comp app users. And we see that approximately sort of 1 million moments are shared each quarter. So people are using it and they're using it more and more. We also see that the people that use this Comp, they have it as a lifeline most of the time. So it's a very, very important device for the people using it. And you can see, okay, it's on. So you know that they have woken up that morning, they probably had breakfast, and then you can see it's off. So they went to bed. Like it becomes a very daily routine sort of thing. And we also see that Comp became extremely popular when COVID hits, and our sales graphs are like, they correlate completely with lockdown rates, which is of course because you feel the sense of urgency when you also feel it yourself. It's available all over Europe. It's sold in these countries, but it can also be used anywhere with the right adapter, and the app is also possible to use everywhere. So we know that there's Comps in India and New Zealand and Nigeria and everywhere in Canada. So it's definitely a popular device. And we also see it's very popular amongst those that can't really hear that well, but use sign language, because you can have sign language through the screen in a very easy way, which is a group that we didn't even think about when we developed this. And we also see it being used a lot with people with other kind of disabilities, so not necessarily just seniors. That was like my brief introduction to Comp and the tools that we're making. Thank you very much.
That's fascinating, absolutely fascinating. And I've seen some fascinating stuff during 30 years of working around social care and healthcare. but not that one. So add that one to the list. Fascinating. I'd like to have a conversation with you outside of this. However, today I'm going to move on to our next speaker, who has joined us today from one of our European Connected Health Alliance members, Orca. Some of you will be aware of Orca. I'm pleased to introduce Sam Shah, who's very kindly moved his schedule so he can appear today and tell us, I think, some really important. I give it almost like a thought leadership on what technology can do around isolation, but also some of the tools that Orca have helped to collate and push. So Sam, I'm not going to talk anymore. You know more about Orca, probably forget more about Orca than I have ever learned. So please, over to you and welcome. And you need to unmute your microphone, please.
Well, hello everyone, and good afternoon. Thank you so much for inviting me today. I'll just tell you a brief bit about who I am, which will give you some context. I'm a clinician, and I still work in the NHS in the UK, but I also used to previously be the National Director for Digital Development of the National Health Service in the UK. So I've been working with digital health and technology for quite a while, and for Orca, I'm the Chief Clinical Digital Advisor, and I support the strategy and the way in which Orca as an organization thinks about how we engage with the ecosystem and the work that we do. A bit about Orca by a brief introduction. So Orca basically does a number of things, but one area is that Orca reviews various products in order to improve quality, safety, and trust around digital health and technology. And it happens from either organizations coming to Orca or from developers coming to Orca. And Orca produces some libraries that individual organizations might use that may include, for example, applications and technology that support people, whether it happens to be around managing the impact of isolation, symptoms that emerge, or it might be around other areas that are related, be it mental health or otherwise. That just gives you an idea. Obviously, I won't go on about it too much, but you can go to the Orca website and freely download a lot of the reports that have been produced around digital health. But I'm not going to just talk about Orca, but I am going to explain to you my perspective when it comes to the use of technology and how we can think about isolation. And I'm going to give you two contrasting views. I'll start with perhaps what is the more controversial view. And that is, could digital health and technology itself be a contributor to isolation? Well, it's probably no surprise to anyone listening, and certainly from my academic research, that this is an area that we need to be thoughtful about. Because if we think about the very reason that technology is successful, that very same thing can itself, inadvertently sometimes, lead itself to different types of isolation. Of course, at the moment, we might be thinking about isolation in a particular domain, in a particular age group, in a particular profile. But of course, technology itself can contribute to the release of or contribute to the way in which dopamine is released in individuals. And you can see that. If you think about anyone that uses Facebook or Twitter or any other product, they get that sense of anticipation that creates a response that means that in its own right, technology become great for addictive behaviors. And that's fantastic for organizations trying to get people to use their technology a lot more. But at the same time, technology might be the thing that we might be using in order to help people when they deal with the symptoms of isolation. And I'm sure other people earlier today have probably spoken about some of those symptoms, so I won't go back to those, but we know some of the clinical symptoms that arise from isolation, be it anxiety, be it depression, be it types of compulsive disorder. All of these things can emerge when people are faced with situation scenarios of isolation. And there's, of course, lots of different types of isolation. I've bucketed them together. I'm sure people earlier on may have spoken about the different types of isolation that exist. And what's important is that not all products are equal in the way that they deal with these things. So if we think about the work that Orca does, we assess lots of products and we assess them on a range of criteria to work out how good those products are, or maybe not so good. There's room for development. And what we certainly found, if we look at the disorders, the conditions that emerge when people might be facing isolation, so anxiety, depression, compulsive disorders, fear, stress, mood changes, all of these things, we know that people are both looking for technology to solve these, but we know that more people are suffering from these symptoms. And certainly the last year, during the COVID period, more and more people are searching for things to help them with these things that could emerge when they're facing isolation. And if we look at the conditions and the quality of the products by condition, certainly from the work that we've done, we found that, for example, we can see that general mental health products don't score too well, actually. They score around 32%. They need more development still. And those things that score really well, so products that are more developed that can help people, especially when they might be facing isolation for different reasons, could be around addiction, it could be around cognitive behavioral therapy that they might need, might be self-harm prevention. They do better. But products that don't do so well around depression, schizophrenia, bipolar. So I know I've only got a few minutes and I'm not going to dwell on this too much, but I'm really happy outside of this session to connect with any of you that can reach me on Twitter or LinkedIn. I'm sorry I couldn't stay for the whole session earlier today. I was chairing another conference. But basically what I would leave you with in terms of thoughts, we need to do a lot more to encourage the digital health community, the digital therapeutics community, the technology community to make better products that meet a human need, that are high quality, that are safe, and that can solve a problem. And right now, we're not quite there. We need to do a lot more work to get better quality products that will help people. So I will pause there because I think I've used my 5 minutes, but please do connect with me afterwards. You're very welcome to, and I'd very much look forward to continuing the discussion afterwards.
Thanks for that, Sam. Fascinating. And I think one of the questions people do ask quite often is if we're so connected, if every single part of our life is physically connected or virtually connected, how come we can still be even more isolated? So technology isn't necessarily always the answer. And that, I hope, is time for us to have a small discussion. We're overrunning, and I think that's I'm giving you all permission. If you want to go on to your next call, please do. But if you want to stay around for the discussion, I'm just going to have a little brief discussion with our panelists here, if you're up for that. Just a question, certainly, if I could, to bring Sam, whilst you're fresh in our minds there, is have you seen people who have tried technology see that it doesn't actually help them, and that almost makes their mind up to think, I'm not going to try anymore? Or do you think people have got staying power to keep coming back and try other technology, in your experience?
Absolutely, great question. Two things happen. You take society split into 3 buckets: people that are digital first, people that are digitally engaged, and people that are digitally disengaged. They're your 3 buckets. 13% of most populations are digitally disengaged. Even however much technology you throw at them, they're not going to use it. Nothing will change them. So that group, you almost know, it doesn't matter what their experiences of tech, whether they like it or not, they're not going to use it, and they probably won't get back to it. The group that you can change, that we have the power to change, are the people that are not the people that use digital every day for something in their lives, whether it's banking or shopping or something else. The people that you can change, the people that are digital first, they might use it for one thing. That's the group we need to focus on. And in that group, we see 2 things. If you give them a poor quality experience once, you can switch them off until they have a clinical need, an emotional need, or a practical need. Those 3 things are the drivers, and the emotional and the practical need are the biggest drivers. So even if someone has a bad experience, if they have a high emotional need or an even higher practical need, that will be the driver for them going back to some technology. But that's not a good reason for them going back, because we need to optimize the experience. So I've seen both. I've seen people that will switch off because they're digitally first or disengaged, and people that will come back to technology because suddenly they have an overarching need, like COVID. You have to get a telehealth appointment with a GP. They'll go back.
Thank you for that. Very, 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 very useful. Anna, if you're still here, from Norway, what's future? What's this time next year for the Comp platform, do you think?
Well, what we're working on with Comp is that you have the computer, and then you have what we call the family app, which is the app that you connect, but you also have a desktop software, which allows you to send out to many comps at once. which is used more and more by institutions and by the municipalities that sort of provide the health services. And we also see there's a need for so many things. So we're looking into physiotherapy, pre-recorded videos, GP sessions, but also audio books. Yeah, we want to have like an endless amount of opportunity that you can actually use your comp to that doesn't affect the easy to use effect that it does have. So
Okay.
I think that it can be many things, but we have to do it with a lot of user design in mind.
Okay. And I'm going to be slightly cheeky because I can do this, you see. It's the enormous power of being a man in blue with a blue forehead. I want to ask then, what's blocking? What's the headache for you? What in terms of getting to that point?
I mean, we are sort of working to that point, but of course it's expensive to develop things. You need money for developers. You need to have the resources in the organization. And then you also need to find the right way to do it. Like we tested out a remote control for comp, for instance, and it was like we needed to use our tests so much because we tried a joystick, but that did not work. And then you need to try and try and try and try. And so it's finding the sort of perfect middle way, and it takes some time, but we're ready to sort of launch our physiotherapy service very soon. So we're taking it step by step.
Okay, thanks for that. That's helpful. Okay, I'm going to fly because we've got lots of ecosystems here. Unfortunately, Pascal's had to go. Mark, if you're still around, Mark Brindle. I'm not sure if he is. And I should come back to you quick.
Still here.
Yeah, Mark. Why aren't we engaging with younger people? Do you think on mental health? Because I've been. This is not a new issue. It was the same issue in 1990, whatever I started doing mental health work, and we don't seem to be listening anymore.
I think it's about the frameworks that we are caught up in, and without being rude, it's a certain amount of red tape and protocol, and for the right reasons. And it takes time, particularly in the research community. You know, with the ethics, you know, it's really difficult to engage with young people. However, the solution is iterative work. You know, small scale projects that talk with young people directly, engage young people directly, give them the benefits of it, and able to help them support other people like them in the short term, using that data to develop future iterations for people like them. I think that seems to be the solution. Yeah, and it was really, Sam, it's really interesting to hear what you said. I'd be good to hook up with you afterwards because there's a lot of crossover with what we're doing in mental health and with NHS. And I think if we've learned anything over the last year, is that if you get the right people around the right table with the right needs, you know, NHS can turn things around quickly, and so can academics. And I think that's the solution, is to take advantage of the expediency that we've seen over the last year to ensure that we are engaging with young people, and we're engaging in a ongoing long-term basis, not just small interactions or small interventions, but bringing them in as part of the conversation and over time. And I think that's it has benefits for them immediately. So you get two hits. You get the benefits for them of them feeling empowered, them feeling of helping people like themselves, their sense of being able to stand back and look at their own position, and towards self-management. All those are like immediate returns, but then you've got the benefits of them helping design and co-design future interventions for people like them. I don't think we can lose sight of that model. The problem we have at the moment is the word co-production, which is, I'm going to say it, it's frankly insincere. You cannot involve anybody patients, participants in co-production, because ultimately somebody's got to take the responsibility of the time, the quality, and the cost of developing these interventions. Patients and participants can't do that, but what they can do is be involved in the co-design of them. We can start with them. We can address their needs from the start rather than imposing interventions on them. So I think that's part of the solution, is to look more co-design model rather than co-production, to involve them from the start and to involve them in an ongoing basis, which includes showing them the end results, because they take a sense of pride in it.
Thanks for that. I think that's borne out by the values with our ecosystems, which is leading with the need and involving patients and citizens at the start, at the heart of the ecosystem. So that's borne out there. I think I've got time for a sneaky last question, if possible, to Dr. Elizabeth. If you're still here, Dr. Elizabeth. Thank you, Brad. Just a quick question in terms of your professional practice and your input earlier. Do you think that there's been an increase in the extremes of psychosis that are related purely around loneliness, or do you think that's not something you could measure, or just in terms of your day-to-day practice, have you seen an increase in the levels and intensities of psychosis?
Yes, some yeah and some no. We see an increase of psychosis mostly due to use of drugs. So we really see a quantitative increase, but we don't see an increase in psychosis not related to drugs. But the topics of psychosis change. You're responsible for the COVID, or you can cure COVID, all this. Yes.
Yes, that sounds familiar from the work I used to do too. So drugs don't have a very helpful effect at all. Listen, I think we've had a small discussion. We've run out of time now, but before we go, as I said, these thematic innovation ecosystems, especially on this one on mental health, are permanent and are multi-stakeholder. So we've got a follow-on from this, and we're looking for involvement and inclusion from people who have been here today, because we want to hear from you. So our next topic is going to be around the area of child and adolescent mental health. That's going to be taking place on the 16th of September, the same time as today. So all the people in the UK, that's 2:30. Everyone else across Europe, Western Europe, that's 15:30 CET. But we're going to have the same model again, the same idea. What is a need around child and adolescent mental health? What does good look like? And where are there opportunities to collaborate? Because that's the concept around ecosystems. It's the same with our geographic ecosystems as well as our thematic ecosystems. What we don't necessarily need to target for the next time is purely around COVID. And we might just want to look at the area around child and adolescent mental health. And not because COVID's going away, because it's not, but just in terms of restructuring that. So get involved, contact Alexia and Mara, who are both on the call today, to let them know if you've got ideas around what some of the needs are, what does good look like, etc. Because we want to hear from you, and we also want to hear from you on social media. You'll see some input as well. And if you've got any questions, please contact the speakers. I would personally like to thank all the speakers we've had today, starting with Ian and then with Stacey. Also, thank you very much for both of your inputs and stepping up. Both of you were both ECH Alliance members. It's important to hear from our members at these ecosystems, but also to thank our speakers, Dr. Elizabeth from Cologne Bonn, from Pascal in Canada, also from Anna in Norway, Alexia talking about the Shapes project, from Mark up in the Highlands and Islands. I think we've had some fantastic input, and then Sam at the end coming in and with the insight and the knowledge from Orca has been vital. I'd like to thank you all for coming along. Obviously, we're just about to hit summer, and some of our ecosystem networks are already gone. We will be having other news around this topic, so stay tuned. And if you've got any other input, contact me. I shall leave my my email address here on the screen for everyone. But personally, thank you all for attending. If I've missed anyone off on the thank yous, I'm very, very sorry. Personally, also like to thank Alexia and Amara for organising, and Martina for your technical support too. My name's Andy Beaton. Thank you and goodbye.
Thanks, Andy.
Thanks, Andy. Thank you, everyone.
Thank you.
Bye bye. Thank you, everybody.
Thanks, Ian.
Take care.